Now I will talk on hip displacement in cerebral palsy. Hip stability in the growing child is highly dependent upon muscle balance. The cerebral palsy children have a 30% risk of hip displacement. The joint muscle relationship is seen in this condition. And then what is hip displacement? Hip displacement is defined as a migration percentage of more than 30%. Then what is the migration percentage? Migration percentage is defined as percentage of femoral epiphysis outside the lateral edge of acetabulum. Then overall it is the migration of the femoral epiphysis outside the acetabular edge. Then what is the importance of the hip displacement? Why we should give importance to the hip displacement, or why we have to diagnose it at an early age is because of its natural course. Displacement in children with a CP progresses with the growth and often causes pain in adolescence and adulthood. The pain is because of non-concentric pressure on femoral head and lack of reciprocal femoroacetabular cartilage nutrition. If left untreated, progression ultimately leads to degeneration, collapse of the cartilage and femoral head, and pain with hip motion. Then slowly child will develop a deformity of the hip joint. Fixed deformity will develop. That is why we have to understand the natural course and we have to diagnose it at the earliest and treat it. Hip surveillance. Hip surveillance is effective for detecting and managing hip displacement in cerebral palsy. Yearly radiographic examination of abduction range of all at-risk children or of children whose abduction is asymmetrical or measures less than 45 degrees from the midline on each side has been shown to lower the incidence of dislocation. Coming to prevention of dislocation. Dislocation may be prevented by treating children under age 8 who have mild early displacement with adductor or a psoas muscle lengthening, or by treating children who are older who have more severe, more than 50% migration or displacement, or a recurrent case with a femoral osteotomy. Injections of a botulinum toxin may temporarily increase the range of abduction, but they don't meaningfully reduce the rate of hip displacement in children with a cerebral palsy. Coming to the reconstruction of the dislocated hip. Reconstruction of the dislocated hip by lengthening of the adductors, medial hamstrings, psoas, combined with the femoral iliac osteotomy is a highly effective procedure in non-ambulatory children with a cerebral palsy. Effect of hip reconstructive surgery. Surgical reconstruction successfully reduces these hips and improves the quality of life of the children. Maintenance of reduction was better in children operated on at an older age. Higher preoperative migration percentage were associated with the lower quality of life scores. We can stage the cerebral palsy hips into 4 stages and we can treat them. First one is hip at risk. In that, hip abduction will be less than 45 degree with a partial uncovering of the femoral head on radiographs. In such cases, adductor release, psoas release, hamstring lengthening will serve the purpose. But monitoring of the child is very important. Hip subluxation. Already hip is subluxated. There is a disturbed sentence line. Then in such cases, adductor tenotomy, varus derotational osteotomy and pelvic osteotomies are recommended. Spastic dislocation. In spastic dislocation, hip is frankly dislocated. Such hips require open reduction with a varus derotational osteotomy plus or minus femoral shortening and pelvic osteotomies to maintain reduced. In wind swept hips, one hip is adducted, other hip is abducted. Such children need a soft tissue release plus or minus a bony procedures to maintain the head reduction. If a child grows up with a subluxated hip and if he develops arthritis and if it is painful, we can do a total hip replacement, but we have to select the patient properly. The indications include the ability to walk. The child should be able to walk. There should be a reasonable bone density. The canal should be well developed and there should be an acetabulum. Minimal to no hip joint contractures. There should be minimum soft tissue contractures should be there. With these indication, the results of hip replacement in patients with a cerebral palsy are good.